Thanks for connecting to this virtual poster presentation and discussion with a recent AMCP Foundation Best Poster Awardee from the 2025 annual meeting in Houston, Texas. Next slide, please. The AMCP Foundation Best Poster Competition is hosted at both the spring and fall AMCP meetings, and we want to thank Artia Solutions and CVS Health for their generous support of the competition. Next slide. My name is Jeff Heater, an AMCP Joint Research Committee member, and I will be moderating today's virtual presentation. Next slide, please. So as we get into the presentation today, just a little bit about the Joint Research Committee, or JRC for short. Our committee objective is really to promote and encourage not only the creation, but also the dissemination of credible research and the initiatives to advance patient care services within the managed care pharmacy setting, with the ultimate goal of improving healthcare for all. The initiatives to support that objective, there's three. The first one is to develop and update research agenda that identifies but then prioritizes the critical evidentiary gaps that we find within managed care pharmacy. The second is to disseminate research agenda to evidence generators, funding bodies, as well as others that are an advocate for or participating in the research initiatives and addressing those evidentiary gaps that were previously identified. And then finally, and one of the great ones, is to cultivate student and practitioner interest within the research that is being conducted within managed care pharmacy. Next slide, please. So within the JRC, there is a managed care pharmacy research agenda that was developed and has four main pillars where we look and identify the evidentiary gaps and focus. And the first one is real-world evidence, which is used to inform managed care pharmacy decision-making. That second pillar is focused more on value-based models within managed care pharmacy, and how does that address the total cost of care? The third pillar is benefit design and utilization management strategies, and what is their impact on patient outcomes? And then finally, when we look at direct patient care services that are provided within managed care pharmacy, what is the impact of those on the patient outcomes? Next slide, please. So we're pleased to be joined today by Danny Nguyen, who is a Best Poster Virtual Presenter and Best Poster Awardee from the AMCP 2025 annual meeting in Houston, Texas. Danny, it's great for you to join us today, and I'll turn it over to you.
Yeah, thank you so much, Jeff. And again, my name is Danny Nguyen. I'm the staff resident pharmacist here at Humana. Next slide, please. All right, and today I'll be talking to you about my topic, my research topic, which is unmanaged depression and chronic disease medication adherence in Medicare Advantage beneficiaries, a novel claims-based analysis. Next slide, please. All right, so start off with a little bit of background here. In 2022, over a quarter of the patients enrolled in Humana's MAPD plans who had hypertension, hyperlipidemia, or diabetes also had comorbid depression. And based on literature search, depression is associated with lower adherence to medications for comorbid conditions. And due to this lower adherence, depression is associated with poor health outcomes in comorbid conditions, including high rates of mortality and hospitalizations. Guideline-directed management of these depressions may help reduce the adherence issues and improve overall patient health outcomes. And lastly, it's currently unclear how depression management is related to CMS STAR's medication adherence measures for these common chronic conditions, and we wanted to dive further into this. Next slide, please. Starting with our primary objectives, the first one is to develop a novel claims-based measure in order to classify patients as either having managed or unmanaged depression, and we did this using clinical guidelines and the help of clinical expertise. The other primary objective is to assess the difference in adherence to chronic disease medications in patients with unmanaged versus managed depression. Next slide. So starting off with the methods, this was a retrospective analysis of administrative claims data using Humana Research Database. So we utilized ICD-10 codes to include patients who had a diagnosis of mild, moderate, severe. And so what we wanted to measure in this was the rate of unmanaged depression by index severity. We also wanted to measure the proportion of days covered, or PDC, and adherence to diabetes, hypertension, and or hyperlipidemia in the calendar year 2022. As for inclusion criteria, we wanted to ensure that patients had a diagnosis of, again, mild, moderate, or severe depression during the index period of January 1st, 2022 to June 30th of 2022. We also want to make sure that those patients were also eligible for CMS STARS adherence measures for those common chronic conditions during the calendar year of 2022. And then lastly, we want to make sure that they were continuously enrolled in an MAPD plan during the 6 months pre-index period and the full calendar year of 2022. As for data analysis, the analysis were stratified by depression severity and chronic condition adherence measures. We also utilized logistic regression models that were adjusted for baseline demographics and health covariates to evaluate the association between unmanaged depression and STARS medication adherence. We also reported the percentage difference in odds of adherence for unmanaged patients relative to managed patients by severity and chronic conditions. Next slide, please. So continuing on with the methods, we're going to go over the guidelines we developed to categorize patients as either having managed or unmanaged depression. And as I mentioned previously, we utilized clinical guidelines and advice from and expertise in the behavioral health field to develop these criteria. So starting off with the managed, if a patient met any one of these criteria, we consider them as managed depression. Starting off with the first one, patient had an outpatient diagnosis code for depression in the primary third position and a claim for depression psychotropic agent within 30 days. Or a patient had a diagnosis code for depression in third position and a claim for psychotherapy within 30 days. Or they had a 9-day supply or more of a single depression psychotropic agent, or 2 more claims for psychotherapy. And then lastly, they had a diagnosis code for depression remission, or they went from a higher severity down to a lower severity in their last depression claim. Moving on to the unmanaged criteria, the first one is if they had an inpatient visit or ED visit, with depression being their primary reason for their visit. And the second criteria is that they were not managed, meaning they did not meet any of the managed criteria listed above. Next slide, please. Now we'll dive into the results here. So utilizing the novel claims-based measure of depression, the rate of unmanaged depression was 26.6% among those who were mild, 17.6% among moderate, and 19.3% among those who were severe. And I wanted to hone in specifically on the severe depression cohort because they demonstrated the poorest performance and may benefit the most from interventions. And so on the table on the right-hand side, we'll kind of list some key baseline criteria for those patients who had severe depression. And as you can see there, majority of patients, the average age was 65, majority of patients were female, white. We also listed Hauser scores there, and that kind of demonstrates to you the risk patients have of adverse events. And those patients who were unmanaged had double the score of those who were managed, meaning they're at higher risk of adverse outcomes such as hospitalizations and mortality. Another thing I want to highlight was the use of psychotherapy. It's 4.5% among managed and 3.8% among unmanaged. And the numbers are fairly low, and that's due to one limitation of our study. Utilizing claims data, we won't be able to see it if patients seek psychotherapy and pay for out-of-pocket. So majority of patients we'll see is through ICD-10 codes and pharmacy claims, which is why we see 89.3% psychotropic use in managed and 48.2% in the unmanaged group. Next slide, please. All right, continue on with the results. We're going to start with the bar graph on the left-hand side. This will depict the mean PDC for unmanaged and managed severe depression by CMS STARS chronic conditions. So all the bars in the blue will depict patients who are unmanaged, whereas the bars in the green will depict patients who were managed. So compared to the patients who were managed, those patients with unmanaged depression had lower unadjusted proportion of days covered to medications for diabetes, hyperlipidemia, and hypertension. And these findings were consistent throughout all the depression severities as well. Now moving on to the force plot on the right-hand side, this will depict the adjusted percentage difference in odds of adherence for those who are managed versus those who are managed. So looking at the median line starting at the 0%, there, anything to the left of that median line will depict a lower odds of adherence. And as you can see, those patients who were unmanaged consistently had lower odds of adherence to medications for diabetes, hyperlipidemia, and hypertension, which is also, again, consistent across all severity levels. One thing I'd like to point out is that patients who were unmanaged with severe depression had the highest difference in odds of adherence, with over 40% of those patients being less likely to be adherent to medication. And again, as I mentioned previously, the patients with severe unmanaged depression perform the poorest in all of our studies and may be the most beneficial target for intervention. Next slide, please. Right. As for conclusions, depression management, specifically those with severe depression, is associated with better adherence to medications used to treat common chronic conditions. Unmanaged depression may contribute to lower compliance to STAR medication adherence measures and may affect plan ratings. And then lastly, claims-based measures for depression management can be a useful tool for health plans and PBMs to develop clinical programs to help increase the receival of guideline-directed depression management. Next slide, please. All right. And lastly, I would like to give a huge shout out and thank you to the Humana research team, as well as my preceptor, for all of their support and guidance throughout my research journey.
Great. Thanks, Danny. That was a great overview of your poster presentation and the research that you did, and really interesting data and outcomes from the study as well, especially as Medicare Advantage plans look at their STAR measures and especially on the adherence measures. What can they do to make sure that their patients are getting the needed care that they need, that they're being prescribed and stuff. So that's great information and great research. Thank you. So if we kind of think back to the four pillars that I talked about on the research agenda earlier in our discussion, as you think about those four pillars, of those four, which one does your research fit within, and a little bit about why?
Yeah, thank you so much, Jeff. So my research closely aligns with the first pillar, real-world evidence to inform managed care pharmacy decision making. I believe so because it utilizes administrative claims data to develop and apply novel measures of managed depression grounded in clinical guidelines and expert input. So by linking depression management to clinical guidelines, we can kind of see how it adheres to medication use for chronic conditions, and our findings can provide actionable insights that can inform targeted interventions and support the development of programs that are aimed to improve patient health outcomes.
Yeah, that's a great overview. So definitely follow with where you're going there with the real world evidence to inform the decision making. And I do think that there's a lot of good information that organizations and others that are familiar with your research or even this presentation could be able to take back and help them with their decision making. So thank you, Danny. If you don't mind, just a few questions. I know we've gotten to know your research a little bit and kind of get to know you a little bit as well. As we think about, just the research that you did, there's a lot of different things that you can do as a resident and different topics and those type of things. In particular, what was the reason or what was why did you focus on this particular research? I guess is the best way to put it.
Yeah, thank you so much. Great question. For me, I was motivated to pursue this topic in particular because there was a high prevalence of behavioral health and comorbid chronic conditions within our MAPD population. And our pharmacy team is always seeking ways to improve patient health outcomes. And I saw it as a great opportunity to investigate whether better depression management could support adherence to therapies for other chronic conditions. In addition, this topic also holds some personal significance to me, as I have friends and loved ones who are affected by behavioral health conditions. And so this connection helped deepen my commitment to better understand how managed care pharmacy can proactively support mental health as part of holistic care.
Yeah, great. Thanks, Danny. That's definitely good reasons for sure. But also good outcomes from the research that you did really, I think, kind of falls in line with that as well. There's with the students, residents, graduates that we talk with over time, each one as they approach the research, went through the process, presenting it, and all that. It's different process for everyone, and there's different learnings as individuals go through the overall process. What was one thing that you learned through the whole process of putting your research together and then ultimately presenting it at AMCP?
Yeah, great question. So this was my first experience conducting official research. While pharmacy school did provide a brief introduction and a great ground foundation work, this project offered me a much deeper, more hands-on learning opportunity. So for me, luckily, I was fortunate enough to work with an incredible research team that kind of guided me through the process, helping me develop my foundational skills, understanding key analytical methods, and becoming a little bit more comfortable with the research language. And despite encountering some unexpected findings and limitations using claims data, I truly enjoyed immersing myself in the data and just being able to uncover meaningful insights. And I just learned so much throughout this whole process.
Yeah, that's great. Yeah, and I think you will probably learn the most through the first time going through conducting research. And you're right, you learn a lot going through pharmacy school, but then once you actually kind of get into the middle of it, there's a lot to learn through that as well. So thanks for that, Danny. So kind of next steps from that, you've gone through this. What advice would you give others that are just getting into research, whether they're students, residents, graduates, or even those that may be practicing pharmacy for many years?
Yeah, of course. Great question again. For me, I would start by familiarizing yourself with the core concepts to kind of establish your solid understanding of the terminology, the methodology, and literature search techniques. And as I mentioned previously, pharmaceutical does a great job of laying the groundwork. So then for me, the next steps would be to develop your analytical skills by learning the various types of statistical analysis, because there's a lot out there. And then using that to, and then also along with that, participating in journal clubs. And I feel like doing this will kind of help enhance your ability to interpret data, analyze the results, and draw meaningful conclusions. And then the most important advice I would say is I would recommend finding a mentor who can give you that hands-on experience with research. And along with that, they can also guide you and give you feedback throughout your research journey.
It's great. Danny, thank you so much for joining us today and for putting the presentation together and for sharing your research and outcomes with those that are going to watch. So, Danny, thank you so much for joining us today.
Yeah, thank you so much for having me. It's been a pleasure, and it's just been a great honor to be able to be here today and even win that award.
Yes, congratulations, Danny. We'll go to the next slide, please. So we want to thank you all for listening, and for more information on the AMCP Foundation Best Poster Competition, the Joint Research Committee, and poster presentation resources, please visit AMCP Foundation's website. Next slide, please. Finally, there is a new AMCP Collaborate community that is available to AMCP members. The Managed Care Research Community is designed to facilitate the exchange of ideas as well as information and encourage in-depth discussions related to managed care research. Join today and engage in innovative and thought-provoking research discussions. Next slide, please. Again, we want to thank Artia Solutions and CVS Health for their support of the Best Poster Competition. And I want to thank all of you for joining us today and learning more about the Best Poster Competition and learning more about Danny's research. Thank you very much for joining us.